you able to hear us? Rose, can you hear us?
Yes, yes, I can hear you.
Thank you.
Uh-huh.
All right.
Support last year, I just can't remember. I'm sure in prior years.
Good morning. My name is Dawn Mautner. She, her, and they are my pronouns, and I serve both as your Medicaid Medical Director here at the Oregon Health Authority and as your chair for the Public Employees Benefits Board. I'd like to welcome you to the November Public Employees Benefits Board meeting and appreciate those who have been able to make the trek for an in-person meeting today. Thank you. And I'm not sure whether we have any board members joining remotely at this point. We'll have to see when and whether that happens. Everyone's here. Okay. All right. So let's go ahead and call this meeting to order. And we can start with a roll call. And I'll do it by audio so that those online are aware as well. Siobhan Martin, Greg Klauser,
Here.
Cheeky Flowers. We think Cheeky's out this morning.
Yeah.
Yeah. Andrea Folks.
Present.
Good morning. Billy Hendricks.
Good morning.
Good morning. Sean Parkman.
Here.
John.
Morning.
Emily Wong.
Here.
Good morning.
Good morning.
And Rep. Nose let us know that he was not likely going to be able to participate with us today. All right. And with that, I'd like to acknowledge, as always, the turbulent environment in which we are serving as public employees, express my gratitude for the work and service of public employees across the state of Oregon. And for today's conversation, I'd like to name a touchstone to which I keep returning as I think about trying to deliver health and health care in today's times. As a clinician, as a family doctor, I was trained to use evidence to make decisions in a patient-centered decision-making context, and I like to return to evidence and science as the foundation upon which we make our best clinical decisions in partnership with patients. So, as other pressures, financial pressures, geographic pressures, pressures of equity, political pressures, impact the work that we do in terms of coverage and plans and insurance and the work of health and health care, I'd like to remind myself and others that the foundation of the best care is the evidence. In returning to that, I have to acknowledge that evidence keeps changing, and with it, our practice needs to keep changing as informed by evidence. So even though we have to navigate all the rest of those political and financial and other kinds of pressures, as long as we can keep coming back to providing evidence-based care, that sounds to me like the best care that we can try to offer from PEBB's very early days, from days past when PEBB was covering preventive care before it was mandated. PEBB has done that, and I appreciate that history. And that closes my remarks. Would you like to chime in, Siobhan, or shall we move ahead with minutes? Yeah.
I just wanted to say, in addition to what you're saying, I appreciate folks coming together in person so that we can have further discussions about the direction that we're leading, reaffirm our values. I definitely appreciate the leadership of previous boards, and I do think that these are challenging times around our healthcare and how we want to continue to make sure people have access to the care that we have said they should have access to in their benefits, and just recognizing there's a lot of pressures around continued access to care.
Thank you, Siobhan. To refer back to the meeting minutes. Board members, have you had a chance to review the minutes?
So I reviewed the minutes, and to the ones that are written, I've already asked Rose just to make the update that Dawn did lead our October meeting. So it just needs the update that she called the meeting to order, and she closed the meeting. So I know Rose is going to make those updates, and those were the 2 updates that I saw. So once those are made, I would put forward a motion to approve with that correction that Dawn led the meeting and closed the meeting.
So is that the September 16th? Because mine already says that Dawn called the meeting to order.
So at the top where it says October 21st, 2025, those are the ones that we're approving today. Oh, mine, the paper version, oh, do you have an online? It
I
says-
know I have a
The
paper
version
version.
says,
Yours is
Oh.
different than mine.
So I must have printed the last version then.
Oh, maybe she already emailed it out, because mine says at the top, Vice
Yeah.
Chair Siobhan Martin called the meeting to order, and that was actually
Yeah,
Chair.
this is totally different than that was updated, I think, last night. I'm just out.
Oh, so you must have the most up to date.
Look at me.
So we
So
can approve
see,
the updated
so
version.
it's already been corrected,
we
and
can
so the
approve
motion
the
is to
updated
approve,
version.
yes, we just
I-
need the
I will
updated
second that.
version.
okay, Siobhan
The
has
updated
moved,
version.
Greg has seconded.
Yay.
All board members in agreement to approve as corrected, say aye.
Aye.
Any opposed? And any abstaining? That vote passes, the minutes are approved. Thank you. And we can move on to the VSP annual update and mobile clinics. Do we have Valerie Swires and Louis Martinez? Rose, are our speakers online and do they need to be unmuted?
I don't see them on
Don't see them online.
I don't see them online either.
Is there anyone else online who has, or in the room, who has insight about this, or other speakers who have, or people involved with VSP?
Yes, hello everyone. My name is Chantel Gordon. I'm the Senior Account Manager.
Good morning.
Good morning. How is everybody?
We're doing well. Are you speaking for us today?
I guess I am.
Somebody's.
Surprise, surprise. I did know, I apologize if they're trying to log in
Uh-huh.
and I think they have a different link.
I see Valerie.
Hi there.
There
But
goes.
I will say that Valerie has lost her voice.
Oh. All right.
So Lewis should be joining.
Yeah, hi Chantel, I just
Okay,
jumped on.
perfect.
Hi, everybody. Sorry for the 3-minute delay. We were in another virtual meeting room just talking to each other saying, where is everybody?
I'm glad you were able to find a link that worked for you. We're glad to welcome you. Are you ready?
I am ready, yes. Thank you so much for having us. My name's Louis Martinez. I'm the Regional VP for VSP in the great state of Oregon, as well as the Upper Pacific Northwest. So happy to be with you. As Chantel mentioned, I am pinch hitting today for Valerie, who is on, and she will be active in the chat And as I told her this morning, as we were talking about this opportunity, that I hope I do her justice because, Valerie loves working with you all, and she was very much looking forward to this meeting and providing an update. But unfortunately, her voice didn't accommodate that. So I'm here in her place, and I just wanted to open up and chat a little bit more about VSP because this is our annual opportunity to check in with you at PEBB. As many of you are familiar with our program, we've been partners for a very long time. We've actually been a vision care provider for over 70 years. But in 2025, I just wanted to level set with a couple of pieces of our value proposition that make us unique still as we enter into the next year ahead. And the first thing is that we remain a totally personalized benefits company. So when you think of VSP, you think of customization first, customized products, a customized network, a customized way that we approach servicing our clients like PEBB. And then the second thing I think you'll notice is we are 100% member centric. So we do everything with the member experience in mind. And I think the example of the mobile clinic is going to give great insight into that. And then lastly, we endeavor to be industry shapers. So being kind of the pioneer in vision care, we expect not only to create great momentum today and in the past, but also 5-10 years into the future. So we're looking at new modalities of care. We're looking at tech-enabled smart eyewear. We're looking at how AI is going to affect the patient experience, and we're dabbling in all of those things. So if we have time, happy to take any questions about that, but wanted to just let you all know kind of where we're at as we just celebrated our 70th year anniversary, and we look forward to the next 70 years in working together. So with that, we'll go ahead and jump into what we had prepared for the meeting today. And one of the big things that we wanted to share was just do a readout on the recent mobile clinic that Valerie put on back in August over in Burns, Oregon. Now, if you've been a part of these meetings before, you'll remember that we did also do pop-up clinics in both 2023 and in 2024. Those were over on the coast, over in Coos County. So this has been an ongoing partnership and an ongoing project with the main focus on bringing the care to the patient. So earlier I mentioned kind of new modalities, whether they're handheld or whether they're on-site, but we have to find out better ways to reach the patient where they are, especially in some of these rural areas around the state. I saw a stat the other day, and it's not just unique to Oregon, because 120 million people in the US technically live in a health desert without proper access to primary care. So there's a lot of momentum here, and VSP is highly focused on how we bring the care into the field and meet the moment where people are. So this is a great thing that we've developed. And it was Valerie was there, and she shared that it was almost like an eye doctor's office, right? The great people at the school district there in Harney County offered up their space. We came in a couple of days early, set up a dispenser area, set up an optical area. We were doing full comprehensive exams. So that includes the exam and the retinal screening if the patient wanted it. We had one credentialed optometrist on site, 2 opticians in addition to Valerie. And this was a full in-network experience. So On-Site Eyes, who was the third-party company who we used to administer this, is an in-network VSP provider. So it was completely seamless to the patient. They were only responsible for their copays. When it came to frames, it was almost like a full eyewear boutique. There was 250 designer frames on site that members could try on, and they got their full benefit plus an extra $20 towards it if it was a VSP branded featured frame, and then 20% off the balance. And then the other thing that was unique about this particular event is we opened it up to include other clients that we work with who might also have employees in the area. So we opened it to CIS as well as OEB. And then not only to our OEB members, but we also open it up to any MODA OEB members as well. So we were trying to be inclusive, and we were trying to make sure that everybody in the area had access because they're all of our clients. And we figured, hey, we were doing a lot of legwork to put this on. Let's make sure we maximize and get all the appointment slots filled. So here's how it went. Over the course of our time there, we saw 53 patients for eye exams. 20 of them were from PEBB. We dispensed 36 pairs of glasses, and about half of them were from PEBB. So those were some pretty good results. Just to give you a comparison from the previous events that we put on in Coos County, in 2023, we did 81 exams in Coos, and in 2024, we did 70 exams in Coos. So this one was a little smaller, but again, I think we expected that because less people, less population. So that was a good thing. We view this as a success. The other things that we learned are listed here, and we could talk a little bit about our learnings. One of them was that it was important to leverage VisionWorks to provide the eye doctor. So believe it or not, we had a very hard time finding a eye doctor to participate in this event for us. We struggled, and then ultimately we were able to find a doctor who worked at VisionWorks, which is a VSP owned optometry outlet, who I believe came from the Eugene office, if I'm not mistaken. There's a VisionWorks over in Eugene. We leveraged our relationship with them, and that doctor, Dr. Rita was her name, was able to provide the care. So that was a big learning for us. So next time, if we do this again in a rural area, we'll probably lean on VisionWorks just because of the tie-in and just because of the partnership. Oh, thank you, Val. She came from Bend. Thank you for that. The other thing we learned is that one doctor is enough. So we kind of averaged it out, one doctor per day for every 300 or so members. So we think that was the right number. If we were ever to work at a bigger location, we would probably just add additional days, not necessarily doctors. Sometimes we'll do 2 doctor lanes, but we're thinking that 1 is the sweet spot for this. And then the other thing that we learned is that the marketing is really important. So we did have great support from PEBB on the posters and the announcements and the email reminders. That was critical. And if we were to do this again, we want to make sure that we continue to have that support because we want to get the word out and we want to make sure that folks are coming in. Any questions on the mobile clinic? Anybody by chance participate or get their eye exam there, or did anybody hear any feedback?
I haven't heard any direct feedback. I did when you did the mobile clinics in Coos County, and it was very positively received. I'm curious where you're going to go to next and how you do the analysis to decide this is the community we need to go to because it's a long distance for people to get their eye care. We haven't had people being able to receive what they need. So if you have any insight into what your next step plans are for mobile clinic.
Yeah, that's a great question. Thank you for that. And I was talking to Valerie about that too earlier. What is next, right? So when we look at our list, and Valerie also recommended maybe we go to Baker County next, which has about 400 people, but they only have one provider within 40 miles. So that could be the next one. We do think that moving these around makes sense because if you remember the results I gave you for Coos, they were actually diminishing year over year. So we went from 81 to 70. So it might make sense to kind of sprinkle it around like we're doing and then return back and kind of have a working rotation. So maybe Baker County would be next. And then, also just a reminder to everyone, we've committed at VSP to sponsoring one of these every single year for the foreseeable future. So we fund these. Valerie and her team do an amazing job coordinating them. We do use a third party, On-Site Eyes, to help support the administration and bring the optician. But Valerie and her team are heavily involved in the planning. We pay out of our budget for the doctor, as well as their travel, and in this case, their hotel stay. So this is something that we're committed to providing one time per year for the PEBB contract. So we could do Baker next, I think, if unless somebody has an objection, and then we can kind of maybe think about how we want to sprinkle these around on a regular cadence.
Thanks, Louis. This is Ali Hassoun, Director of PEBB and OEB. I just wanted to say thank you. I think this is, Siobhan mentioned access at the start of the meeting. This is a direct result of, communicating when you hear from your members where there are access issues, and then, we can take that to the carrier, VSP in this case, and, they were fully on board for figuring out the solution, and just kind of snowballed there to where we could leverage, OEB and in that area, and school districts, and even CIS. So yeah, I think we heard feedback from the school district there, and it's nothing but positive, and I think they really appreciate that. So yeah, thank you. Thank you.
Yeah, thank you.
Thank you for that partnership, and being innovative about getting care to the areas of the state that have less access. I don't know whether you would be prepared to speak to this in real time, or if it's something we could follow up on. But what interests me is zooming out a little bit from that, acknowledging that what this does is fill a hole in a sort of a network adequacy picture when people are spread out far and there aren't high concentrations of providers for people to be able to access. This is one of the ways that we can take care of where they are. And the way that we put that together systematically, looking at the whole state, needs to acknowledge where we have lots of care per member, easy access in all the ways of equity, and then the places where there might be holes, harder access to be able to put into motion. So I would welcome a kind of a systematic look at access and how this might be used to help strengthen the network in those places. And Baker sounds like a great next step as well.
Mm-hmm. Yeah, no, thank you both. I really appreciate that question, and thank you, Ollie, for your comments earlier. But yeah, to that latest question, I totally agree. A systematic approach and kind of more detail-driven approach would be very helpful. I know right now we're kind of anecdotally looking at the various counties and seeing where, just based on a geo-access report, there might be opportunities. It's worked well so far. But to your point, we are working on some specialized heat maps, I guess you can call them, that are in development right now. And Valerie is actually a part of a pilot program at VSP where we're looking at like a map of the state of Oregon, and we're mapping out our network, and we're mapping out the membership, right? Client specific. So in this case, PEBB specific. We're looking at where there are access gaps. And then the other layer we're looking at is potentially where are people who are living with diabetes or hypertension or high cholesterol, where an eye exam would be even more important, right? Because those of you who look at the health plan data every day know that people who are living with diabetes are at major risk for eyesight loss. So with VSP, we pay special attention to that population. And we want to make sure that if there are layers of data that we can put on top of each other and really pinpoint with great accuracy where the holes are, then we'll be able to use this solution to go in there next. So we are working on that. And Valerie made a great comment in the chat that in our first quarter meetings, we usually do some planning around this. So hopefully by the first quarter, that pilot program that she's a part of will be able to provide some mapping that we can review together and just verify, is Baker the right place? It very well may be, but there might be something that we learned from the data that we didn't know before. So I appreciate that comment, and I think we're fully aligned to making that happen.
Thank you.
Okay, so just a couple of other things that we wanted to cover. I thought this was fantastic. I'm glad Valerie pulled this together because, you know, setting this on-site mobile project aside for a second, we just wanted to, you know, take a step back and look at over the years the impact that VSP has had in the state of Oregon since the inception of the VSP Eyes of Hope program. So the Eyes of Hope program is a national program where we endeavor to help the communities that are most in need. As most of you might know, VSP is a not-for-profit vision plan. So we invest 3% of our margin back into the communities that we serve. It's our obligation as a company. And so what Valerie's done here is she's broken down kind of what we've done since 1997 in the state of Oregon. We've actually visited the state of Oregon with Eyes of Hope and with partnership with Oregon nonprofits 35 times since 1997. The investment there is over $3 million. We work very closely with the Pacific University College of Optometry and to do different events. So there's been 23,000 free eye exams and eyewear that have been donated to Oregonians, as well as scholarships. So I mentioned the work with some of the College of Optometries up there. We actually sponsor and give grants to fourth-year optometry students and pay for their tuition to help them launch their career in optometry. So these are just some really great results, and we thought it would be nice to share in an update like this, not only what we're doing nationally, but what we're doing right here in your state. And with that, I think I'm gonna hand it over to Chantel just for the last few minutes of our time together to just walk through just some final things that we've done in the form of an executive summary.
Yeah, thank you so much, Louis. Like Louis said, we wanted to prepare a couple of things to show you and to make sure that you are all aware of some of the things that we've done kind of behind the scenes. All the member materials and the client-specific website, we've been able to translate that into Spanish. And we completed that ahead of the October deadline to ensure accessibility to those Spanish-speaking members. And I know PEBB is very concerned about equity and understanding for their members. So I know that was very well received from the membership. During March, they had the Vision Awareness Month, where we had VSP ambassadors, Dr. Harden and Dr. Torin, host 3 live events. The focus of the events, educating the members on eye health and the importance of regular eye exams as part of their overall health care. Performance guarantees, VSP has met all the performance measures from quarter 1 of 2024 to quarter 2 of 25. Which demonstrates a consistent quality and reliability and service delivery. With that network utilization, which is proof that the PEBB members are truly using the plan and they're staying inside the network. The network remains a high 96%. In March of 2025, VSP acquired iMart Express. And so that added 5 rural retail locations to expand access. And those were in Bend, Corvallis, Eugene, Medford, and Roseburg. iMart Express, they are the third most popular out-of-network provider with 60 claims the last 12 months. So those that were previously out of network will be considered in network for the members. And then there's the member savings. VSP implements cost controls and negotiates the discounts on exams, lenses, frames, covered and non-covered options. And then after the premiums, members have saved over $19 million in the last 12 months by having the VSP coverage in place. Were
That's
there
great.
any questions on any information that was shared?
Yep.
Yeah, please.
This is Greg Klauser, board member. Not for the free clinic, or the clinic that you had, but I know a while back, the east side, Hermiston, Pendleton, greater area over there had lost one of I think their 2 doctors. And I was wondering, I know that there was a letter sent out. You guys did a very good job with that. I'm just wondering how we're doing on trying to see if there's another doctor in the area. On your map, I know when I looked up today, all of the doctors that we have in our area are in Tri-Cities, which is about 35 to an hour and 10 away, depending on where you live there. So just a question.
Yeah. Thank you for the question. I could speak a little bit to not to that specific. I'm not fully in touch with the specifics on that one. Sounds like Valerie is, and
Okay.
anytime we lose a doctor, I will say we fight. We fight to keep them. Valerie specifically is very in touch and close with our provider network development team. So sometimes we hear of these pending terminations. A lot of times our clients will bring it to us. We might hear it from a member. The doctor themselves might start proactively sending out a letter to their patients that we get wind of. But we do everything we can to renegotiate those contracts and secure and retain as many doctors as possible. Sometimes we're unfortunately unsuccessful because many of these doctors, or if not all of them, own their practice,
Yes.
make their business decisions based on how they feel is best for them. And there has been a lean away, not just in vision care, but dental care as well, a lean away from working with insurance companies. So we're fighting against some of that. So I will say VSP has a plan. One is to negotiate hard and retain our network, which we've been pretty successful at. The other thing is through acquisition. So what Chantel mentioned around iMart Express, that was a big acquisition this year. We added almost 300 retail optometrist locations all throughout the US, 5 in Oregon, and iMart specializes in quote unquote rural areas, more rural than city. So it was a great complementary acquisition for VSP to make sure that we're continually looking at ways to have a strong network. The other thing that I'd like to share is that we also launched a ventures group. So we call it VSP Ventures, and their whole existence is to acquire practices who maybe want to, maybe the doctor wants to retire. Maybe they don't want to do the administration or have the burden of running a business, but they still want to practice care. So they may want to sell their practice. Instead of selling it to a private equity company who may not have the best interests of optometry at heart, we would like them to sell it to VSP, and we will manage it and put it in network and support them the way that only we can. So we've actually started a venture group within VSP for that very reason. So there's different things that we're doing to try to shift the market and make sure that we have some better controls around the patient experience and the network experience. So I really appreciate the question. There's lots of work happening. And it sounds like maybe in our next meeting, maybe Valerie will have an update on that specific doctor negotiation.
Thank you.
Yeah, thank you. Great question.
Hi, Louis. This is Emily Juan. Can you hear me?
I can, Emily. Yes, hi.
Okay, great. Yeah, thank you so much for all that information. And I actually had a couple of follow-up questions from an equity perspective. So when you were in Burns, Oregon, and it sounds like you had some really great partnerships going, did you partner with the tribe also? Like, were some of the folks that came, members of the local tribe there? And then also appreciate the Spanish member materials, and just curious if you had any plans to do other languages. Asian Americans are the fastest growing population in Oregon. I think they've increased at least 25% in 34 of our 36 counties. And so just curious if you have any plans in expanding to other languages.
Yeah, great question. Maybe I'll take the second one first around the language translation. We can absolutely support additional languages. Chantel, maybe you could speak to that a little bit more, but I know that we have the capability and we have done it for other clients. We would ask which ones specifically that you would want translated, but we could certainly support that because we, as you are aligned in the equity and want to make sure that materials are available in the native language wherever possible. Chantel, do you have anything to add to that?
No, just that we can definitely look into that. I would work back with Valerie and with the board to determine what languages that were they would like to look at first, and then I'd work back with our marketing department, see about getting that done.
Emily and board, the health equity work group is going to talk a little bit later about specific tactics the board is interested in furthering health equity. And one of the ideas we have is to think about what the next language would be that we would want to ask about and pursue. So languages, right? Yes. Slowly over time we want to work on that. So
okay,
we'll have a conversation about that. Yep.
Just FYI, our OHA tribal health director is from the Burns area, so can be a resource for that area. Thanks.
Yeah, that's wonderful. And maybe as follow-up to this meeting, maybe we could send out just some existing available material that we do have available to translate. So we could provide that as follow-up just to maybe spark some ideas as to what's available kind of off the shelf. And then Valerie did help me with that question. Looks like we didn't have any tribal members at the pop-up clinic unless they were employees of OEB and PEBB. So that was her response to that question because she was there on site.
Okay, thank you.
Thank you. We have a couple more.
This is Andrea Foltz, board member. My question is, since you're funding scholarships and grants for students at Pacific University, have you thought about utilizing that to help maybe have them do externships or go to some of these rural areas for a few years and, give them bigger scholarships so they can do that? I know it's a lot of logistics to try, but I was just curious if you had looked into that.
Yeah, that's a great question. We could definitely take that as follow-up. I think it's a great idea. I know that we do the scholarships, we do the grants, and we do some endowment scholarships with that College of Optometry for people that are pursuing an MBA. So yeah, it's a great idea to maybe see if in return, they would go to an area that is underserved, and maybe it's a different scholarship amount to do that, and maybe it's a longer term contract. So definitely a creative approach. We'll be sure to share that with our network development team. And then as Valerie also mentioned here, thanks Val, we do have a loan repayment program. So those are just the various ways that we support the local doctors. But yeah, there's probably opportunity to continue to do more.
Great, thank
And I
you.
know that we have a doctor-student matching program for those seniors. It has to do a lot with matching them, those that are graduating, instead of necessarily going out into a retail practice to learn, working with a provider that's actually looking at retiring. And so finding a student that's ready and willing to make that move, we always are, there's a department that works with the students with that as well.
Oh, that's great, thank you.
Thanks for that question, Andrea. I'm always interested in workforce pipeline investments from our partners, especially in the places where access is a struggle. Those workforce pipeline programs have some very good evidence for strengthening the network and access over time. So thank you for that. Sean, did you have a question?
Yeah, I did. Thanks. This is Sean Parkman, board member. I have a follow-up questions about the total savings comment previously, and particularly I'm interested in the kind of frames section. And I'm just kind of wondering, I'm curious about where like savings in comparison to what? And here's a little bit what I'm up to. I've noticed in my own experience that a lot of the frames, you know, are amazingly priced, somewhere about $30 more than what most insurance covers. And I don't want to accuse any of the frame companies of like price fixing or anything, but let's just say that they have a number in mind. So I'm just curious, you know, like the technology needed in order to make frames hasn't super changed as far as I know in the past 100 years. So I'm just kind of curious, like, are you tracking that? And like, how do you, is there pressure in the system to essentially like tame? I mean, theoretically, the way a free market's supposed to work is that there is a purchaser, which in this case is insurance, at least partially, that is basically, you know, looking at competitive prices and then saying like, no, that's outrageous. Just because it has a Nike swoosh on it, we're not going to pay $100 or whatever. So I'm just kind of curious, as a company, are you kind of tracking that sort of like frame prices? How are you describing the savings there, like in comparison to their open market non-insurance price? And like, is there any kind of way that you're sort of putting pressure on the market in some way to sort of like control itself?
Yes, great question. And yes, VSP is very interested in the frame market. With all transparency, right? We own a frame company. So VSP owns the third largest frame company in the world, called Marchand. And Marchand is the manufacturer of Nike, the swoosh, of Calvin Klein, of Ferragamo, of Lacoste. VSP actually just acquired a company, it's about to close, it's a French company called Marcolin, and they make Tom Ford and about 30 other brands. So as a company, VSP is in this space head first. And to your question about how do we make sure that members are getting the best value, there's a lot of work that's being done around that. One of the things that we do from a network perspective, when network doctors want to join our provider network, we require them to carry 60% of inventory that is within VSP's National Book of Business Frame Allowance. That National Book of Frame Allowance is $150. So by contract, if they want to participate on our network, 60% of their inventory has to be at that threshold or below. Because the last thing we want is to put a doctor in our network where a patient walks in and can't afford anything. So that's a requirement. So that's one of the ways that we're pressure testing the system. The other thing that we do is when we process claims, on the back end, we process the claim based on a wholesale amount rather than the retail amount. Now, there's a lot of computations and calculations that go into that, but what I want to share about that is it protects the member from excessive markup. So if a doctor who runs their own business prices a frame way above markup because they can, maybe they're in a rural area or maybe they're in a luxury downtown retail setting and they mark up, when that VSP patient goes in and buys that frame, behind the scenes, we are applying the wholesale equivalent benefit and only charging the patient what is truly required. So maybe we could talk about more about that, the way that works at a future meeting, because like I said, there's some bits and pieces to that, but that's another way that we protect our members from that markup. And then the last thing I'll mention is, because I mentioned the fact that we are in the frame business, the way that we pass that on to our customers at the point of service is the $20, the extra $20 for the featured frame brand. So we didn't want to buy a frame company just to buy a frame company. We wanted to make sure that we were leveraging it to pass on the savings to the people who need it, right? So when you buy a Nike, when you buy a Lacoste or a Calvin Klein, you'll notice on the plan summary, that's considered a featured frame, and you get an extra $20 to put towards that benefit. That VSP funds, not PEBB or not the member. 22%, thank you, Val, 22% of frame claims that went through the system for PEBB was for a featured frame, and that member got an extra $20 towards their allowance. So there's different things that we're doing to make sure that we're passing along the savings and protecting the member out of pocket and basically taking control of these companies so our competitors don't, right? And making sure that we leverage them to support the patient. So I hope that answered your question.
Yeah, I appreciate that conversation, and I wasn't super tracking that y'all also were the purchaser and the seller at the same time. So I think it would be good for us to talk about. I mean, I think the board has experience over its career that across the entire insurance quadrant, there has been a lot of industry consolidation, and that's what I'm hearing. Mm-hmm. And that industry consolidation has not really benefited PEBB, frankly. Yeah. So that would be good for us to follow up and just to talk about how you keep the lines clear as far as conflict of interest between, you know, fixing prices to coverage and how that's containing costs and what consequences, unintended maybe, consequences there might be to the amount of industry consolidation I'm hearing. So yeah, that feels like a follow-up maybe.
Yeah, happy to do that. And we could also bring on, maybe if we have a planned meeting, bring on an individual from, Marchand or from our frame division to speak in detail kind of about the overarching strategy. But yeah, certainly a worthwhile conversation.
That's a good follow-up.
Ollie?
Yeah, this is Ollie. Just maybe in our first quarter meeting, if we could talk a little bit more about that $160 cap or payment, and kind of when that's reassessed, or has it changed over the years, and just learn a little bit more about how that's determined and the impact of members.
Yeah, happy to do that.
Thank you. Good questions.
Yeah.
Anything more from the board? All right. Thank you so very much for your presentation, for your work to deliver the benefit that helps our members achieve the health outcomes that we are trying to support. We think our increasing dependence on screens is potentially impacting our need for vision care, and I'm happy to work with you on how to provide that care. Thank you.
You're very welcome. And on behalf of Valerie, we want to say thank you for the great partnership, and Chantel. So we look forward to our next meeting and next steps. And if we don't chat with you, have an amazing rest of your year. Happy holidays, and we'll speak with you very soon.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks all.
All right. Next on the agenda, a U.S. health policy update. Andrew, I think we might be getting ready to hear from you.
Yes, I can sort of set the stage a little bit, make some somewhat brief remarks before I hand it over to Wade Simons, who I'll introduce here in a second. And so we're going to shift gears a little bit and talk about the current political landscape that we find ourselves in. And that's I'm referring to the federal political landscape. And so we're going to spend some time in the next, I think we have 45 minutes, if I'm remembering correctly, going through what the federal administration is doing with regards to healthcare, some potential impacts for plan sponsors such as PEBB. Obviously, this is a really tumultuous time. There are a lot of unknowns, but nonetheless, we want to make sure you're all aware of what's happening and potential impacts to PEBB. And then our plan was to sort of get grounded in what's happening in the environment. And then in the next presentation, we're going to segue and talk about health equity, get regrounded in PEBB's values in health equity, get refreshed, talk about health equity tactics as we look to the 2027 plan year. And so these two presentations do sort of hang together. We thought we'd start, if we could jump to the next slide, by just hearing from you all to the extent that you're comfortable sharing or that you've already thought of concerns that you have related to the PEBB benefit program operating in the current environment. And then Wade, maybe you could comment on, to the extent some of these concerns are things that you're going to cover in your discussion, that'd be great. This is Wade Simons. Wade is our regulatory leader at Mercer. He is a trained ERISA attorney by training, a longtime Mercer consultant. And so thanks, Wade, for being here. But if we want to first start, and if any board members have any concerns with regards to PEBB's values and missions and what the next 1 to 2 to 3 years looks like in terms of operating in the current environment, and we welcome that. So I'll pause there and see if anyone has anything that they want to share. And maybe your concerns will come after the presentation. I acknowledge that too, but just want to make sure if there are things that you're thinking about, that you're concerned about, to the extent we can hear about it up front, Wade can potentially weave it into his facilitation of this discussion.
I will name it. I have many concerns, and in particular, I know in Oregon, we're looking at budget shortfall, and budget shortfalls impact people across the spectrum, across the healthcare spectrum, including PEBB. So, we've had to come out with budget cuts, and, we're always facing economic pressure on PEBB, and when we have a health system that's strained, and when we have a federal government that is putting out information saying they're going to withhold funds, whether that's Medicaid funds, Medicare funds, if particular services are rendered in the state, by our institutions. I think that is extremely problematic for PEBB when we've made commitments to offer particular coverage so that people have the best health care that they can get. I worry a lot about laws that are getting changed or pressure that is put on states and threats around funding being withheld that is going to impact our members' care.
And I would just add that, we've got probably at least 2 biennium that are going to be horrific for the state of Oregon. So just, Ali sent out a wonderful email to us about kind of how we're funded and kind of to get everybody grounded on how PEBB is impacted by some of these things. But I think that, just from DOC standpoint, like we were ramping up to gather all the food out of our cupboards to feed the SNAP people that weren't getting SNAP benefits. So it's real in our agencies. So it's just something that we're, it's not going to be just this biennium. I think we're going to at least 2, hopefully not much more than that until we cycle again, but it's real for our agency, so.
Yeah.
That's why.
That's true. Yes.
Yeah, I would just piggyback off of that, or just knowing that our social safety net is unraveling. And then what, 1 out of 3 Oregonians are on our Medicaid program, 1 out of 5 are on SNAP. It's just going to have major ripple effects. I mean, our families, our communities. So yeah, we're so reliant upon the federal funds to do a lot of our innovative health systems transformation work even, so.
Yeah, thank you for sharing that. Yeah, Sean.
So a couple of concerns. So more than a couple. One is, it seems like a lot of the policies in general are essentially pulling back from supports, particularly for rural Americans, but so rural Oregonians. And there's just a lot of places where that kind of shows up in weird ways that we're not going to have the time to get into, but let's say like housing policies and various other things, subsidies and so on. And so that just has a trickle down to our members because we're in every single county. And so there's that. So there's that. Then there's supply chain uncertainty, including pharmaceuticals, just because of, well, I don't need to go into it, you know what. So there's that. My main concern is that there's really, as far as I can tell, there's no national strategy to actually adjust the insurance landscape in ways that need to be done. I mean, I think I've said many times, I don't think this is particularly controversial here, but like insurance in the United States is broken. This is like very broke. Healthcare in the United States is broken, in my opinion. And there's really, as far as I can tell, there's no real adjustment to that, no actual strategy. It's more just like taking things, or just like yanking out things. So just kind of like a lack of change leadership in that, I think is just going to keep rolling us forward. And more specifically about that, this transition at some point between sick curve versus well care in our healthcare system, right? We are absolutely a sick care system, and our food environment essentially makes sick people who then, then we try to pay for being sick. And there's nothing changing about that. There's no plan to change that as far as I can tell. I was thinking about the other day about pharmaceutical prices, this is what and I actually looked this up. So since 1980, there's been about 1,500 new pharmaceuticals brought to market in the United States. And in that same period, our life expectancy went down 2 years. So it's like, what are we doing? So like we're not gonna prescribe our way out of anything. We haven't. Like that has failed. That's a failed experiment. Not to say that people shouldn't have them. I'm just saying it's not the so there's just no plan for that, changing the ship. And it's just at this point we kind of need a plan, and we're just wasting time essentially like that. I'm worried about transgender care and like where that's going. That there might be more restrictions that actually really affect us. So I'm worried about that. Vaccination rates are already down. We have the lowest vaccination rate among nurses in Oregon for flu in I think a decade this year. So that's already happened. So just that little dial around like anything that the United States does, which is minimal around preventive care, just given the food environment and so on, we're very much swimming in the opposite direction. So we have a couple of things that we do, such as vaccinations, whatever, and we're losing even that. So it's basically, we're just 100% sick care. So I'm worried about that. And then just the pullback on money in the system, even though it's, you know, we're not Medicare, there's trickle effects in the system that affect our costs. I think you're going to talk about this in a few minutes anyway, but that's a concern. So.
Yes, yeah, just to piggyback a little on what Sean said. It's kind of ironic, by the way, our one missing board member, Chippy Flowers, is our ECA Marketplace Director. She's at the legislature right now as we speak, talking about the impact on the state of the loss of subsidies. But talking from the state budget perspective, and I think where I struggle the most is, you know, we've dealt with recessions before, and where you can kind of plan out, you know, how you're going to manage these budgets and what available resources you have. These days, it's not really a recession. It's these funding shortfalls from the federal government, and they could really go away overnight or be, you know, exacerbated the opposite way. It's really difficult to make any long-term plans because the administration's plans can change in a lot of ways. So it's just kind of an unprecedented times.
Yeah, I just have one last, because Sean said a lot, and that reminded me of some other things, but I think people with disabilities, I was hearing the headlines this morning on public radio that there were closed door meetings going on with the governor and the Medicaid and Medicare situation, and the folks that were not usually in the room or that were not invited were the people with disabilities, Disabilities Rights Oregon, and so, which they didn't even know that meeting was happening. So that seemed alarming. And then also, I think I've mentioned before here with the Oregon revenue forecast earlier this year showed a doubling of our 80-year-olds in Oregon. And then also I've since learned that our 65-year-olds and above, we have the third fastest growing rate of 65-year-olds and above in the nation. We're tied with Colorado. And so I don't always hear those pieces in, you know, the health meetings that I'm in. So I'm hoping that somebody is paying attention to those demographics of our state today.
Thank you, board. That was a lot of concerns, and I appreciate your bringing them, articulating them here. And so we have taken up some of the time, and I acknowledge that you have a lot to offer. So back to you.
Yeah, and so Wade, I'll hand it over to you. Is it fair to say that many of these concerns we're going to be talking about today, I don't know if we'll alleviate them necessarily, although maybe in some instances.
I assure you we will not. They will remain concerns probably after, as, that's I think, Sean, what you said is right, that, and Ali as well, that we're at a point in time where things can change so fast that, like, even putting a presentation like this together is almost sort of folly, because tomorrow it could be irrelevant. You know, it's just the policies are just so moving so quickly. But when it comes to, like, the legislation, and this is this first slide here, you know, we got the end of the government shutdown last week, but it was really, again, sort of a stopgap measure, like government funding through January, but really nothing truly of substance within the funding bill. And, you know, obviously one of the big Democrat priorities was to get extension of the ACA tax credit subsidies for insurance that went into effect during the Biden administration, and those were, all they got was an agreement within the Senate to hold a vote to, you know, potentially extend those, but the House did not agree to hold that vote. So, you know, even that is sort of tenuous. But if you're not familiar, basically the Biden administration put into place subsidies that created additional eligibility for tax credits for lower income individuals. And then it also created increased amounts of those subsidies. So sort of, greater eligibility at higher income levels plus additional amounts to help pay for insurance. And so that's why, it was deemed to be such a priority to get those back in place, because as you can see here, without those, there's a projection, and this is, nonpartisan Congressional Budget Office indicating that 3.8 million people every year could lose insurance. So essentially unaffordable, so the uninsured population will rise during that time. And there's obviously a cost to this. It's $335 billion. So paying for it is something that Congress will have to deal with. But we also know that there was Medicaid eligibility cuts as part of the 03BA Act. And so just that combined, you're talking about a pretty significant impact on lower income populations as far as being able to afford insurance. So,
can I follow up question?
Yeah.
The 335 billion over 10 years, is that like if they were to extend the subsidies, that's what it would cost? Is that what that is?
Yeah, just like keeping them in place.
Okay.
That's what the cost to the federal government would be.
There's a flip underside number of that, which is if people are uninsured, this is where we were before the ACA.
Yeah.
Then they don't get they don't get treatment, whatever, then they just end up in the emergency room anyway, once it's a crisis.
Right.
And now we're back to crisis care. Is that a number that anyone has that you're aware of?
I've been asked that question before, and I haven't come across that in anything that I've seen. But
because I think that number may affect us.
Yeah.
Because because the general system would be more expensive, and two, like as we take on as we hire people, there may be untreated this and that, that suddenly, like all of a sudden, like, oh,
Yeah.
what are we serving,
Yeah, I mean, layers of costs, and I kind of tried to touch on a little bit on the next slide, talking about what are the implications for health plans. Anytime you have an increase in uncompensated care, providers have to find a way to get that offset, right? And so they can't do it to public programs because reimbursements are capped. So typically it's going to go back to commercial insurance and increase costs there, which generally means premiums will go up, claims costs will go up, and so it's sort of inevitable that group health plan insurance, whether that's private or public, will be more expensive. Hard to put a number on that, but that's certainly the direction that it's likely to go. Plus just, additional pressure on the system. If you think about, and somebody mentioned rural care, if you have providers in rural areas, a lot of them are dependent on Medicaid and, sort of these populations that get these low income subsidies. If those aren't available, how do these providers keep their doors open? Rural hospitals and other places certainly are going to feel the strain because folks just don't have the mechanisms to pay for care. So that's the other potential downside is that there's certain providers that are going to really struggle depending on how this all plays out. So right along the lines of what you all were saying. As far as if you go to the next slide, it's as far as what we're looking at in this next, if there's another bill, there's going to have to be, obviously, to keep the government open past January. But if there's, some movement as far as continuing those subsidies, what might we see in that bill? And these are some of the, priorities that were put into a bill at the end of 2024, if you recall, that was ultimately scuttled because several, including the president, Elon Musk, others complained that there was way too much in this bill, and they scrapped it to something much leaner. And so these things could make their way back into a bill which, sort of national pharmacy benefit manager reforms.
Hi, it's James. And please hang up and redial, and I will try to pick up right away. Thanks. Bye-bye.
Okay, bye.
I got it.
So, I don't know if there's anything super notable on here other than, the kind of things that states are already doing related to pharmacy benefit manager reforms, a ban on spread pricing. So, that's the profit margin that the pharmacy benefit managers take between what the manufacturer charges and the end plan pays. There's that spread in between, and that's a lot of the profit for the pharmacy benefit managers. So getting rid of that and making sure that rebates are passed through. Depending on the drug, rebates can be enormous. I didn't realize that, when we're talking about GLP-1s, for example, the rebating of those drugs is often above 60%. So when we talk about sort of like, here's what the retail price is of a GLP-1, $1,500 per month. If you look at what the rebate is, that's 60%. It's actually the price less the rebate is more like $500 per month. So that's really a number that probably should be more the focus than the 1,500. But we'll talk about that in a minute as well. And then just some trying to ban non-competitive practices within the provider and hospital communities, and then true transparency. We have some transparency requirements now, but a lot of it is just sort of best guess and reasonable estimate, and there's really more of a focus on, can we get sort of true transparency of what care actually costs. And that should be not very difficult to do at least on the in-network side, because those numbers are fairly standard and fixed. But on the out-of-network side, much more difficult, just because that varies so much. But we'll see where that goes. And then just going to the next slide, a quick summary of the 03BA Act, HR 1, passed this summer in July. Just wanted to give you the sort of background on this, just because it has an impact as well, specifically based on the cuts to Medicaid, as I talked about before. And you can see there that the new work requirements, eligibility and enrollment rules, additional cost sharing requirements. So all of that combined, decreases the numbers of eligibility for Medicaid. And that was, I guess, sort of the low-hanging fruit from the Congress's perspective, as far as how to try to pay for a lot of these big ticket items within the bill, funding of border security and immigration and defense and some of these other bigger ticket items, and then mainly just the extension of tax cuts that were set to expire, those that went into effect in 2017. So that's kind of where we're at there. And then the next slide gets into some of the drug pricing that has been getting a lot of media coverage. And so all of these terms like tariffs and most favored nation promises and direct to consumer options, all these things kind of fairly new. And so trying to unpack it all can be challenging, especially because it's changing from day to day. So there's tariffs. Good news is that the tariffs are only applicable to the branded pharmaceuticals and not generics, because there was obviously a big concern that if tariffs were assessed on generics, that the supply would dry up, and because there's such a large amount of scripts written on the generic side. I think it's 80% of the scripts written are generic drugs. That was a huge concern. So that's sort of the good news, that may not come out directly in a lot of the media coverage. But then we have the Trump RX, which is the new direct consumer pharmaceutical website that's going to be handled by the administration. That they're trying to find a vendor that's going to be the one to administer this, and they're trying to get it up and running, I think, by January. But we'll talk about that a little bit more. And then Pharma, who's the industry group with all of the pharmaceutical manufacturers, they want to have their own direct-to-consumer website. And so then each of the pharmaceutical manufacturers, as you might have seen, is starting to bring to market their own direct-to-consumer site. So you're seeing advertisements on television with the little QR code that, hey, if you're interested in this drug, click on this code. We'll schedule you with a telehealth visit with one of our preferred physicians, and then you can get the drug that's best for your condition, which just so happens to be our drug. Which, we can talk about the conflict of interest all day related to that. But so that's where we're going with a lot of these direct-to-consumer opportunities. And so where do the pharmacy benefit managers for benefit programs, where do employers fit into this whole framework? And is there a way that they can take advantage of some of this preferred pricing? And that's really kind of the mystery at this point, is we don't know how that's going to filter down. I will say that there was some media coverage that talked about, how the Trump RX website, it's going to be broad-based. It's going to have all of these different drugs. You can see there on the right-hand side, from asthma, infertility, arthritis, diabetes. All of these conditions will have drugs available. However, it really, when you really looked at the drugs that were going to be available on the site, it was a pretty small number compared to the total U.S. drug spend. That might change, more depending on how many other manufacturers join. So at first it was Pfizer and AstraZeneca, but then last week we had Novo and Lilly agreed that they're going to have drugs on the site as well. But again, it's hard to know which drugs and what percentage of drug spend and scripts will be available. So it's a lot of to do. We'll see if it's if it really is meaningful.
So can I follow up on that piece?
Yeah.
So this would be for presumably uninsured Americans, where they just go on and they just buy diabetes drugs or whatever directly at whatever the price is as it is.
Exactly.
And there would be no reason for a PEBB member to go onto the website, because presumably, definitely their pharmaceutical costs would be way less with us. But if they went through our system,
well, we don't know that, I think, at this point, because
I think our copay is like $5.
Yeah.
You know what I'm saying?
Oh, yeah,
There's
right,
no way.
right.
Not for everything.
Right.
It's true.
And the other thing to take into account, hey, this is Sarah, I'm virtual today, is like this could be a route for enrollees in PEBB if they wanted, say, access to those weight loss drugs that aren't currently covered under the PEBB plan. This could be a route for them to purchase them at a lower cost.
Yeah,
But then they're paying for it out of their pocket.
Right.
yes,
That's
although
right. Yeah.
that's what we're hearing from some of our other clients is there a way for us to facilitate access? So can we give employees a pool of money potentially? We don't want to cover it on our plan, but can we give them a pool of money to go out and get that discount pricing direct, but then we'll help kind of facilitate payment for that.
Yeah, what could go wrong with that? So, okay.
Yeah,
So that-
but we don't know because obviously they're clear that they're not going to take insurance, so there's no way to sort of run it through the
They're just gonna
plan.
mail it to them, is that the idea? The drugs?
Seemingly, yes. Yeah.
Yeah, it would be.
I get the feeling you don't need a prescription because you can just, yeah, how do they do that?
No, you
You need a prescription and they, so Trump RX, my understanding is that they're basically gonna be like they'll direct you to the manufacturer website. It's like they're a clearinghouse of websites. And so you'd go to the manufacturer website and the manufacturers like Novo and Lilly have contracts with telemedicine providers, and the telemedicine providers can write the script, or you can bring your own prescription. And in addition to buying it through the websites, a lot of the manufacturers are also offering coupons that can be used at a pharmacy, like GoodRx announced earlier this week that the same prices that are being announced for Trump RX, I think, are also going to be available through GoodRx. So it's changing quickly.
Thanks for leaning in there, Sarah.
Yeah. I'm glad, I didn't know you were on, Sarah, but I'm glad you are.
So are they really clear about this not being extended to commercial insurance?
Yeah, I mean, they basically said the manufacturers and for Trump RX, it's been pretty clear, like we will not take insurance. So it's just a question of will there be price matching? To say, well, if it's good enough for the direct to consumer,
I'm kind of saying that different. So I had a mother-in-law who was not on insurance and had cancer. And so all of her meds she got from Canada. So she went to the doctor, got her scripts. Those scripts were uploaded. At that point, Canada was less than 1/8 the price here. Those meds were then okay because of her script. It was mailed to the house. And she took, still needed a script, but it's done through that system.
Yeah.
So kind of that way.
Sorry. Yeah. So, I mean, if we know what the price is on Trump RX and we fail to get that price on our negotiated rates, someone's a bad negotiator.
That's what I think is the interesting aspect to this is that, everybody's going to know what the price is.
Right.
So why wouldn't commercial plans drive a hard bargain to say, well, we don't want to pay any more than that. Why would we?
Right.
So Sarah, I don't know what you think of that, but kind of feel like
I agree. I agree. The price is out there now, so now there's a target. I mean, our understanding prior to these most recent announcements was that the price that most private insurance plans were getting was in the ballpark of what was available direct to consumer. So with these announcements, the direct to consumer price has gone down. So yeah, the target has gone down, and we would expect there would be negotiation in that regard. At the same time, we're hearing a lot of interest in employer plans trying to figure out a way to support employees that want to purchase direct to consumer. So rather than having it be on their plan, they're looking at different options like health spending accounts or lifestyle spending accounts that could be used for members to purchase these on their own. But that's still all just evolving. And I think there's a lot of, as Wade can attest to, a lot of compliance aspects there too to consider.
Yeah. Let's go to the GLP-1 slide, which is one more. Yeah. So we actually kind of put some of the pricing on here just so you have the visual of it. They actually set out the specific price tags for GLP-1. So as I said, what's $1,500 was out there as sort of the price, and then we're talking about $350 per month or less on Trump RX. So again, so many plans do not cover GLP-1s for weight loss that there's certainly going to be a thought of how can we get employees access to this without us having to cover it on the plan. One thing to keep in mind is that many contracts have what are called exclusivity agreements with your pharmacy benefit manager or your insurer, where it will say, you can't provide access to pharmaceuticals through another avenue without violating the exclusivity agreement that you have with your pharmacy benefit manager. So that's a concern for employers that are looking at, how do we get people access here, is that, that might mean that, the pricing of your PBM contract is blown up because of that exclusivity agreement. So that's something we're going to have to kind of work through as well.
The flip side of that is what I just said, and I just, for the sake of record, for whoever's listening, now that we have prices, clearly stated, I am going to have questions for plans that are not able to negotiate to match or at least get close. I'm going to have a lot of questions. So I just want to be super clear about that, because now it's out. So yes, if they're not able to do it, there will be those questions, but then we will need to talk about what do we do to work around that, because if they just can't make it happen, then we'll have, it doesn't make sense for us to be paying $1,500 when there's another way to do it for $350. That does not make sense. So one way or the other,
prices are going to go down.
That's coming down. That is my expectation, and I'm just putting that on the record.
Yeah. As I said, though, you have to sort of monitor what drugs are available versus, the whole.
Yeah.
Yes.
For GLP-1s in particular is what I'm speaking of right now.
Yeah.
Thank you, Sean. I want to note that Katie from MODA dropped a chat that says we need to remember that when they do go through a different system or outside of our typical claims system, we will not have insight through claims data into the medication being taken by the member or risk stratification and the other things that are done with that.
Nor will it be coordinated by a patient-centered doctor, looking at conflicting this and that. Yeah, we will lose all kinds of control. And there's all kinds of reasons.
The care management function of the health plans is hobbled.
Yeah.
Right? I mean, it's fragmenting care. Like Katie says, the plan doesn't see that. So when they're looking at a member holistically, it's like, oh, this member's on all these drugs, and they don't actually have line of sight that they're on the GLP-1.
Right.
Right. Thank you. Okay.
Yeah, I mean, so just, sorting it all out is basically all the things that we just talked about. We're just going to have to kind of watch all the moving parts. Once the direct consumer websites are active and going and, the pricing is set, then you can sort of move forward making those kind of decisions. Again, good news that we're not looking at, the generics being subject to these tariffs, but the tariffs is just sort of it's different every day. So really hard to put a finger on that. But there's a Supreme Court decision that's likely to come in the spring to determine whether the tariffs are even permitted at all. So that will have an impact on the pricing as well. So just a lot in the pharmacy space, really changing the dynamic.
One quick note though, on what we just talked about, to me that would be up to the patient themselves, because every time I see my doctor, he's asking me what I'm taking, because there's meds that he has on his list that I don't take anymore. But there's also meds that I'm taking. So it would be up to me as the patient when I go see that doctor to say, hey, I'm now taking it, or I'm doing, or I want, which would then put it in our system. I'm saying, you know what I mean? But it's because he's a reporting doctor for, I'm not seeing, my understanding is I'm not seeing a doctor that's outside of our, when I go see my general practitioner for my yearly update or my whatnot, and he says, what are you taking? I say, oh, well, I'm now taking Ozempic because blah, blah, blah. Then that would go into hopefully our system, we could track some of it, not all, but hopefully some of that will come back to us and we can continue to collect.
Well, that will go into the electronic health record, which the physician has access to, this, so the physician will know. But if there isn't a claim that comes through the payer, that the payer pays for, then the plan visibility into that
Doesn't
care
matter. Okay.
is limited or none.
I see what you're saying.
None, yeah.
Because we don't pay for it, it doesn't go on the books.
Right,
Okay.
and so we don't get to
I get that.
CDHR, yeah.
And additionally, what we're trying to nudge the system towards is to be more active than what you're describing your doctor does. That your doctor, because they're aware of what you're prescribing already, not asking you because they're the one paying for it. I mean, the system is paying for it. That they're calling you up with a plan proactively. Like we can, you know, we would like to adjust this like this so that we can get you off of that. You know, if we can do these modifications, this and that. Like that's active management. Yeah. What you're describing is passive management, which is what we're trying to get away from, right? So we're trying to have our system, our networks be more in kind of leaning in to health management, you know, it's like partnership with the patient more of the time, not 100%, but more of the time. And so this basically takes us backwards, where there's just less chance for that sort of patient-centered model, where someone has the big view of like, we can get this person off this drug if whatever, we can prescribe a different, like let's say, nutrition plan or something. That's what we're hoping the system can actually do, which it isn't.
And there are some additional notes in the chat, but that coordination, yeah, it is true that your physician would know. And additional notes, the cost of GLP-1s isn't actually $1,300 at this point. It's probably roughly half that, but changing fast, according to Sarah. And it sounds like there are already prescriptions direct from the manufacturers that physicians are including in their negotiations with patients, according to Dr. Wheeler from Pfizer. And Gina Korab notes that the complexity of the moving parts are complex, but driving to better costs is a win for consumers. And Katie Sheeler notes that concurrent drug utilization review at the point of sale now in the pharmacy is another safety evaluation to look for drug-drug interactions that would be missing in a mechanism to obtain medicine that is outside, again, of a system, a holistic system, a risk of fragmentation. And those are all the chat comments that I see at this time.
I know we're getting close to time, so just a couple more thoughts. One just on vaccine recommendations. So, you know, a lot of concern about, you know, how the federal government's going to adjust vaccine recommendations. The sort of one headline, I guess, was that the COVID vaccine continued to be recommended, but based on what they call shared clinical decision-making. And that generally means that there has to be sort of agreement between the patient and a provider, which could be a nurse or a physician or a pharmacist, in order to get the COVID vaccine and to have it be mandatory at no cost sharing. But of course, plans can choose to be more generous, which sounds like PEBB has done with, you know, aligning the coverage with the West Coast Health Alliance, as you can see there on that note on the bottom. So the one thing to note is that if this kind of shared decision-making is required, then before it would be, you get the COVID vaccine and the plan would just pay the cost of the vaccine. But this could bring in an additional office visit or consultation, and that also would be required to be covered as part of the no cost sharing mandate. And so plans might be looking at additional costs just from that additional consultation with the provider that wasn't there before. I don't know that there's a number to put on that, but it's just something that plans should be aware of.
I think just as a not today, but for a follow-up around COVID and the flu, I'd say, just because we have an intervention for that, which is about, it would be good to get an idea of what our hospitalizations are for those numbers. Like if vaccinations in general are going down. My understanding, and I'm not a doctor, but my understanding is that COVID still has a more severe population-wide, is more severe than the flu on a population level as far as its acuity. And then the flu is no joke, when you look at a population item. So we do end up with hospitalizations every year. And I know we haven't hit true flu season yet in Oregon, so it's usually late. But it would be good to have an idea, like presumably of course our vaccination rates are down. But it would be good to get an idea of like, what is the consequence of that on like actual medical costs? Like it's not just that it would be great if everyone there's a reason why we would like them to get vaccinated is because it keeps you out of the hospital as a population. And if that's going down, then we can expect higher hospitalization rates. So it would just be good to have an idea of what the bleeding is related to that. Like we lost money in a sense that way. How much? Like what size is that problem? I don't know. It may be relatively marginal. We could be optimistic like that. I don't know. But I do think that even the flu shot's down, I think. And so it would be just kind of get a good idea to get our arms around it. Like maybe we get lucky and it's a relatively mild flu season. I don't know if you have any sense of that yet, but in which case it kind of washes out and it's like, oh, but we dodged one there. But I don't know. Now we kind of have two flu seasons every year. We have COVID and the flu, so it's like 1-2 punch. And so I don't know what that looks like as far as our bottom line.
Yeah.
And it would be good to just get a sense if there's a way of gathering that from all three carriers somehow to comparable data, apples to apples or something.
Yeah.
It would be good to know. Yeah, flu hospitalizations and COVID hospitalizations. That's pretty much it, I think. Unless I'm missing something.
Yeah. Will they be tagged something higher? So like in DOC, if somebody overdoses, the higher is maybe their heart stopped because of fentanyl. So they bill us as heart. They don't bill us as overdose, poisoning. So if somebody is hospitalized for a more severe complication from COVID, will it be tracked as COVID or will it be tracked as a higher?
Good point.
There are nuances to how to decide what qualifies as a COVID-related hospitalization. Any hospitalization that includes a COVID diagnosis versus a primary diagnosis. Those are the decisions that can be made when the data are pulled.
Okay.
Yeah.
Good luck.
There are some methods to decide
I think
that.
there might, Emery, do you agree there might be a way to mine that to understand and connect lower immunization rates with higher inpatient costs for flu and COVID?
Yeah, I mean, we have history on the claims, so we can take a look at that and just see if there's tracking. I mean, so we can take a look at it. I mean, part of the issue is 2020, 2021, 2022 is obviously COVID very impacted, and the coding isn't as accurate there as it is now. But we can definitely look into it.
I might be more interested in the pre-COVID era as a comparison point. So like say 2019.
Yeah. I think
Versus.
I think we still have 2019 and maybe some 2018 data, but I believe we still have 2019 that we can take a look at.
All right. Let's go ahead and finish up here.
Yeah, I think we can just wrap it there. The last slide was just talking about the Trump administration won't enforce the mental health parity rule that went into effect in 2024, but mental health parity and substance abuse parity is still the law. It's just that some of the more stringent provisions that were in the regulations won't be going into effect. So,
What's the top line of the consequence of that?
I wouldn't say there's really, other than just plans have less administrative burden from that perspective. You know, I think it didn't change anything related to the parity law itself. I think there's a little bit of misinformation out there that somehow this relieves plans from having to comply with mental health parity, like that somehow the lack of regulation means that the law itself isn't effective, but that's not true. So that's maybe more the headlines, just, you know, don't be fooled into thinking that just because the regulations aren't going forward that the law isn't. So but with all regulations at this point, we're in sort of a freeze period anyway. The staffing at the agencies is so light that, you know, really the only regulations that we're getting are repealing of regulations, not additional regulations at this point. So
Thank you very much for that review. And let's go ahead and take a break. Let's take 10 minutes. It's 11. Let's come back at 11:25, please.
Truck all the way through the prison to get to the bathroom.
Yeah,
Oh my God.
it was terrible.
I'm like, no, I did
Still
it. How
terrible.
could I get there?
Yeah. Worst possible.
Andrew.
Is someone else prepared to open?
I can if needed.
All right. Welcome back, all. It is 11:25 and we'll get started. And we return to reaffirm our health equity values and strategy. So I welcome the Mercer team to go ahead and take the stage. Welcome back, Andrew and team.
Sorry. Seems like I got here just in time. Okay. So once again, I will keep my comments pretty short and sweet, and just sort of help to set the stage as we segue from political environment to getting reaffirmed in PEBB's values, specifically around health equity. And so to start things off, I wanted to introduce you all to Katie Scott, sitting here with me.
Hi, hello.
Katie has stepped into the health equity workstream leader role on the Mercer side. So working with Sharna and other staff members, as well as board members on the committee. There you go, Sharna. to help lead that work. Many of you probably already know Katie. She currently works with the PEBB Member Advisory Committee, as well as the Worksite Wellness Coordinating Council. Fun fact, for those of you who've been here for a while, she helped with the 2020 Health Equity Retreat. You might remember Michael Garrett facilitating that, and Katie participated in that as well. And so, yeah, we're glad to have you, and thanks for being here in person with us. And so the way that we've structured this presentation is to first look backwards and talk about what have the last 5 years looked like since 2020, when PEBB really established equity as one of its core values. Where are we at today given this environment? And then we'll have a breakout group and talk about what does it look like in the future with regards to tactics, health equity tactics and strategies that you want to explore and implement and execute on, given everything that we just talked about with the current landscape. And so with that said, I think, Katie, I'm handing it over to you.
Thank you, Andrew. Hi, everyone. Really happy to be here. Katie Scott. I hail from Los Angeles, so even though I'm not from the Pacific Northwest, I do have a love for it up here. My roommate in college was from Portland. She taught me about Fred Meyer and Marion Berry milkshake, so I do have a love for it here. And I've been on the PEBB account for many years now, so I'm excited to step in and talk with you all today. So really, before we go into background, I wanted to level set with what Oregon Health Authority's definition of health equity is, because I think it is kind of ground us in what the ultimate goal is of the work we do here. So I'll just read it. Oregon will have established a health system that creates health equity where all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. So again, really just a reminder that we're here focused on the member, and really the ultimate goal is making sure people reach their full potential of highest attainment of health, no matter their background. So in terms of just a little bit of background, Oregon Health Authority has had a focus on health equity for many, many years. But since 2020, they've had a commitment to a 10-year strategic goal to eliminate health inequities, and this was really reinforced in their 2024 to 2027 strategic plan. And PEBB's health equity commitment also started in 2020 and really leveraged OHA's guiding principles and definition of health equity. Since 2020, it's been 5 years, right? Here we are in 2025. The PEBB board has made, really impactful health equity decisions over the last 5 years, and we'll go through a timeline quickly here in a moment. And given a lot of what we've talked about today with the tumultuous environment, given that it's been 5 years, we really see this as an opportunity to recommit, double down, and really refresh the health equity strategy for PEBB, but also have some alignment with OEB as well. So really great opportunity there.
So here's a timeline. I won't go through all of this, but just to kind of showcase some of the main highlights over the years. In 2020 was when PEBB's health equity strategy was developed back in a retreat in 2020. 2021 and 2022 were really used to kind of form the work group jointly between OEB and PEBB. A health equity screening tool was developed, which has really been foundational to a lot of the work that's been done over the years. There was also a DE&I benefit vendor assessment conducted both for PEBB and OEB, which we are continuing to leverage over the years, and I think we plan to in the future, where we asked all of PEBB and OEB's carriers questions about their internal initiatives related to DE&I and health equity. In 2022 and 2023, that's when the screening tool, after it had been developed, was really being utilized with vendors for renewals. The legislative screening tool was developed as well. And then you start to see, starting in 2023, 2024, where some really big initiatives had some focus and some real outcomes were, made around doing some work around doulas as well as gender affirming care. And part of that was through Senate bills such as HB 2002. In 2024, the board approved doula coverage, and the CIAO Summer Research Group focused on total worker health. And then this year, really big initiative around doulas really going live, and it continues to be a focus and an opportunity area there. So with that, I'm going to hand it over to Maggie to talk through some of the alignment between OHA core values and PEBB and OEB's goals.
Yeah, thanks, Katie. So as Katie mentioned, in 2020, the PEBB board really kind of set the framework for the health equity work that was going to be done and has been done over the last 5 years. And at the time, OEB joined the work group as well, but had not formalized. And as we've done this work over time, we've seen how this work has aligned. So you may have seen this slide previously. On the left, we have the triple aim, which is historically what PEBB has aligned to. We laid out your core values, including quality of care, equity, affordability, and member experience. And here we're showing this really good alignment with OEB's goals as well as OHA's strategic pillars that were outlined in this latest strategy that was released in 2024. And so we saw this as an opportunity to really kind of take a step back, think about everything that's been accomplished over the last 5 years, and help kind of refresh the strategy and the values and help you all kind of recommit to your values and goals related to health equity. And given this alignment, we thought it made sense to do that in conjunction with OEB if the boards are agreeable to aligning on strategy, but then allow you to kind of determine your own tactics and where you want to go from here. Move forward, please. So yeah, like I said, the opportunity here today is for PEBB to restate your commitment to health equity, to join OEB in an aligned mission, values, and strategy while using your own tactics to get there. And so this little diagram kind of shows the mission and values are what are going to set the foundation. The strategy will help provide the roadmap, and then OEB and PEBB will separately set tactics and will help build the roadmap and framework for the next several years following this meeting. So without further ado, Sharna, would you like to kind of talk through what we're proposing?
Yes, please. Thank you. Hi, everyone. This is Sharna Frian. I use she, her pronouns, and I am the staff lead for the Health Equity Work Group. And this on the screen right now is the representation of what we're proposing as the strategy for our health equity mission and values. And it's kind of broken up into 4 quadrants around the mission. And the mission is to implement, develop, and evolve benefits to advance health equity. So our first value is high value care, where we have programs and benefits that are centered in equitable and quality care with measurable outcomes. That's a really big mouthful, but we try to encompass everything into each value, so they're a little bit detailed, each one. The second one is in alignment with the strategic goal for access to care. And members should have accessible, affordable, and person-centered care that support everyone's unique needs. The third value is being culturally responsive. And members' interactions with the ecosystem should be respectful, inclusive of their diverse cultural backgrounds, geography, and lived experiences. And the fourth value is about removing barriers to health and well-being. And we're focusing on the members' social and environmental barriers, so social determinants of health, and as they're related to health inequities, and this would also include our rural populations. So, are there any questions about that? No? Okay. All right, so here are the strategies that in the purple section or the lavender section, underneath each of those 4 pillars, and you can probably read them, but in case anyone doesn't have access to a screen, we're going to identify some systemic biases that impact health outcomes. We're going to leverage data and include member input and experience under the high value care. So we're getting a little feedback on that so we can find out what's actually happening. Access to care, we're going to offer a variety of plans, which we've already done, and different modalities. Design a balanced approach to financial renewal changes. That is going to be kind of key. And share benefit changes and financial impacts equitably. So not just one population or one group or one entity is going to end up paying the bulk of the change. Under culturally responsive, we want culturally and linguistically appropriate care and require language and accessibility standards. And that kind of touches back to what happened on our phone call with VSP and Emily's very timely question about, well, what languages are we putting all our materials in? And removing barriers, we want to prioritize programs that screen and assess those determinants of health and provide members with educational resources to understand their services. So in other words, they're using them to their best advantage and most economically in their household. So those are the proposed strategies.
And so our goal here, yeah, is to kind of lay the framework to start building momentum towards each of these and really make them actionable, and then we can draw specific tactics from them. But really would love to get any feedback or reactions you all have to these as proposed. Is there anything we're missing or things you'd like to see different?
So a thought. So I see in the big circle in the previous page, right? There's I mean, a lot of these high value care, culturally responsive care, access to care makes total sense with PEB, right? And we have some levers to be able to push on to do that. And I think there's a lot of mileage with that. And we also have this remove barriers to health and well-being, meaning the environmental barriers that contribute to health inequities in our members' environment. That's a trickier thing because that's not a prescription and we don't have as many levers there, right? Mm-hmm. And so the board has struggled with that one for many a year in general, but also in related to health equity. And so one of the ways that one difficult, yet one place where we have a little bit of leverage, or at least influence, which I think that we have had some success with, is with worksite wellness and Teresa's work. And you know, we had a presentation with that. How long ago was that? Was it a couple of months? Not that long ago, right? And you could see like all these things that they had done that we, you know, pretty good. And yet, you know, the work environment is not fundamentally transformed yet, right? We still, you know, we still have potlucks that are mostly desserts and so on, you know, that kind of thing. And I'm really thinking about like, what are we after when we're talking about the environmental barriers that are different, that affect people differently based on their background and so on. And it's really pretty much the 3 causes of preventable death in the United States, but also Oregon, right? There's 3, right? And one of it's the food environment, right? Like nutrition, sugar, basically. 2 is tobacco, actually tobacco, then sugar. If you want to get technical about it. And then the 3rd one is alcohol. And that's it, right? So those are the things that are killing Americans at very high numbers, right? And the way that it kills them is different, right? It's diabetes and heart disease and stroke and cancer and so on, etc. But when you back it up to like, what are those things? It's those 3 things, right? And so, you know, our public health division, as far as I understand, has been sort of gutted with the recent news. Yeah. So that's also happening. But I'm just throwing it out there. Like, I think there's more. That's the one leverage point that we have. We can't just like march in and bust open a door and be like, we're going to do a bunch of things different in our workplaces. But it does kind of make sense that we would be interested in the workplace because we're the insurer, and we pay for it. Like, if the longer you work in the state, the sicker you get. Like, that's kind of interesting to us, right? I mean, because in the end, we pay for that. We have to balance the books. And I don't think, and this is my personal opinion, I don't think that we're going to solve that with a bunch of apps, right? I think that has something to do with a different type of approach. Not to say that apps don't have anything to do with it, but I don't think that's the thing, where we just like, let's buy another thing, and then that'll solve the thing. I don't think so. I think it's more of a policy thing. I think it's an education thing. I think it's a leadership thing. And so I'm just kind of looking through the strategies, and I'm kind of just like not seeing it specifically per se. I mean, it's just like implied, I'd say, but you know, this is probably where we start getting into tactics, which is probably the next activity. So I'm jumping ahead. But I'm just throwing that out there for whatever that's worth, group discussion. Like, I could see a potential overlap with, you know, pretty careful, from what I've observed, a fairly careful, even-handed campaign that public health, our public health has been doing around alcohol with Oregonians. I have no idea what their situation is right now, if they're even still up and running or if everyone's been laid off. I don't know. But I think they've been doing some work that's been pretty innovative in comparison to most states. Like, I think it's Oregon, and there's one other state that's doing anything. So it's like, we may as well, since we're one state out of 2, we may as well, like, is there a way to leverage, you know, like a more of an employee campaign with that, you know? And it's not, anyway, so there's that. There's the food environment. I know Teresa's working on this, like, very hard. And so is the committee, and we just got an update, so I don't mean to belabor it, but it's like, we're talking about a 10-year strategy here, and we're kind of regrouping we're talking, there's room to talk about cultural food and just like changing the food environment inside of and also like the lack of exercise in our environment and so on. So I'm just throwing it open there. I don't think that PEB can be like the single entity that solves our food environment in Oregon, or the tobacco environment or alcohol, but in the workplace, there's a little bit of room for just some open discussion, maybe some discussion around like cultural food and like how when we come together to celebrate, which is very important in our agencies, it's often around food, and it's like, what's that like? And can we have a conversation about that among leaders and so on? So I'm just throwing that out there. That's like one piece that might fit under the barriers to health and well-being area. So, thank you.
One note on that, Teresa has done some incredible work, and we really have the backing of the governor's office and our the Department of Administrative Services director is new. Just developed a statewide memo directing all agency heads to be aware of these resources, reference PEB and Teresa Cross and all the tools that we have, and resources that we can help them put together their own worksite wellness specific to their agency, their demographics, and got a note from our OHA director who's super proud, of the reference to PEB in there. And so I won't say for the first time, but there's really momentum behind, from that executive level to really start pushing into agencies.
Thanks for that.
Yeah.
All right. Thank you, Sean. Any others?
Yeah, it always triggers a lot of thoughts for me. Yeah, I think it would be great to focus on actually workplace mental health and well-being, and just it's great to hear that update, Holly, that there's so much support from the high levels. I think I brought up this model before, the Surgeon General's, the former Surgeon General's report on workplace mental health well-being, lessons learned from COVID, all the experts all over the country who informed this, focused on the worker voice, not the manager voice, the worker voice, and equity, and then the 5 essentials. And so it'd be cool to, I don't know, look at this, as we're moving forward, and other models too that have come up. And then I would just add, like, water and air, I think, are other things that can fall under the environmental barriers that we could remove. Or just, I think about the houses and the mold, the black mold that just explodes in people's homes and makes the whole family sick because it's not properly ventilated. Like the kitchen fan's not properly ventilating and the bathroom fan's not properly ventilating. And is there a way to do like housing and health, kind of thing together? That's just one, these are big brainstorm ideas. But then also I just am reminded of I love how you guys pulled in the biases, because you can do that within the internal workplace, the government setting, but you can also go beyond the workplace into society. And we've had over 300% surge in anti-Asian bias and hate, and which has caused a lot of mass murders and violence. And sadly, in December 2024 report of Asian American mental health for youth, 1 out of 5 Asian American youth do not want to be Asian anymore. They do not want to be Asian. And so that's like, and this is just a community that I've been working closely with, but I think this is also happening with other communities, not wanting to be wanting to be white and not the other anymore. And so, and that just reminds me of the work that we did at OHA. And I tried to pull up a report here on when we were determining the health equity policy priorities for the state. And the number 2 priority was like a shock to all of us. We were like, why do they want the health department to do this? But it was to address biases and stereotypes. And they knew that OHA was not the Department of Education. But this rose up to the top at that time. And now I think it's probably even more urgent than back then because of all the blatant racism today. So I think it could fall under what you guys have, already done here, like in terms of biases, but like that's a big thing that's exploding right now.
These might be some ideas worth exploring in breakout groups. Perhaps. Maybe invite you to set that up. Yeah. That might mean we actually have to get up from our first sitting.
Yeah, so
Around.
we have listed the groups here, and I'm thinking since Dawn, Greg, and Andy are over in that corner, maybe our group will meet there. And then the other folks could maybe come meet in this corner just so sound has a little bit of space between it. That would work too. Yeah.
20 minutes.
Yeah, let's do 20 minutes. And then does anyone need a printed copy of the strategies before we get started, or do you all have paper copies?
They're here.
Great.
Sharna, would you mind muting breakout groups and us moving around?
Well, we had one person that was on the breakout group that said virtual, so I don't know if we
She
can.
did not join.
Oh, okay.